Evening and welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is exploring pertussis, whooping cough in Australia. My name is Susie Blackburn. I will be your moderator. I'm the event manager at the Immunisation Coalition. Firstly, I'd like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and/or Torres Strait Islander people participating in this webinar. I pay my respects to all First Nations communities and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Presenting tonight's session is Angela Newbound, who will be presenting for around 40 minutes. This should leave us plenty of time to answer questions. Please type the questions into the Q&A box, not the chat box, at any time during the session. You'll find this at the bottom of your screen. Tonight's presentation will be recorded, so all participants will be automatically on mute for the event. I'd like to introduce Angela Newbound now. She's an immunisation education consultant based in South Australia and a member of the Immunisation Coalition. She's been involved in immunisation program delivery for over 20 years as a provider, program coordinator, and roles within the divisions of general practice, South Australia Health, and the Medicare local network. She's presently with the Primary Health Network in South Australia. Thanks for joining us and welcome to you, Angela.
Thank you, Susie. And yes, you probably actually are really quite happy not to see my face anyway. So that's actually all good. And thank you so much to the Immunisation Coalition for the invitation to present on this particular topic tonight. I'm in Adelaide, so I'm on the lands of the Kaurna people, and I'd like to pay my respects to elders past, present and emerging, and to all First Nations people across the nation. So, this is what we're going to just be covering tonight. So a bit of an overview of pertussis disease and across the age groups. A bit about pertussis vaccines and effectiveness, of course, because you're all vaccine providers, target groups and coverage rates, and certainly some little bit of a few tips and tricks perhaps for the general practice involvement, and definitely some key take-home messages. So this is just once again just a little bit of a reminder of that incubation period that ranges from around about 4 to 21 days, usually around about 7 to 10 days. Cases are infectious on the onset of that, cold and flu-like symptoms, runny nose, low-grade fever, maybe a mild and only occasional cough that becomes more severe. Of course, that coughing, that paroxysmal stage gets more and more and more because obviously the respiratory tract is trying to expel the really thick mucus from the tracheobronchial tree. Quite often you'll note that parents of children or people that have got whooping cough may well report that their cough gets a little bit worse at night time. They can have several attacks during the day, on average maybe about 15 of these coughing fits, as we call them, in a 24-hour period, and they'll increase over that first 1 to 2 weeks. In young children, quite often you do hear that high-pitched whoop at the end of the coughing fit as they're trying to draw breath, but little babies may not cough or whoop at all. They can just stop breathing or turn blue. Some babies will probably have difficulty in feeding because they can't breathe properly, so always take note if a parent says, oh, it just won't feed properly and she's really lethargic and she falls asleep at the breast all the time even though she hasn't had a full feed. And of course these little babies can choke and gag as well because of all of that mucus. Older children and adults, of course, may just have a cough that lasts for many, many weeks and may not at all have that whoop. So things to look for really for people is, particularly little babies, is cyanosis when they're trying to feed, or if they have any choking episodes. With older children and adults, maybe some vomiting and just sheer exhaustion. Certainly we know that communicability decreases over the first 3 weeks of onset of cough, but we know that secondary attack rates are very high in household contacts, should I say. So we just really need to be aware that, you know, if people are coughing for a duration of time, that they really should be tested for whooping cough. So let's just have a little quick look at the infants, children, adults, through to adults. So this graph just demonstrates the cases of notifiable infectious diseases, and this is for pertussis, as you can see. And I've added in a couple of little points there where we had this jurisdictional level of maternal pertussis programs, but it wasn't a funded vaccine. It was state funded by some states, some territories. It was very ad hoc. Some jurisdictions covered the grandparents as well as the partner, as well as the pregnant woman, etc. And along the way, we had that reintroduction of the 18, well, that's a month booster, not a moth booster, by the way. That's my spelling error. Thank you. So we had this reintroduction. We used to do an 18-month-old booster many, many years ago, and then it ceased because of the number of adverse events that we were seeing, particularly around large localized reactions in 4-year-old children. However, you know, we've got to weigh up the good and the bad and the ugly, and certainly we need to make sure that children are covered against whooping cough, and we don't want those breakthrough outbreaks. So that reintroduction of the 18-month booster. Then, of course, in 2018, we had the maternal program that was funded under the NIP. So rates have really, really declined. And of course, you know, with the onset of COVID, most vaccine preventable disease, respiratory diseases certainly declined as well. If we look at figures, you know, sort of down that 2020, 2021 end, in 2020, we only had 3,457 notifications, and that dropped in 2021 down to only 564 notifications. So far, to the 21st of August in 2022, we've had 305 notifications. So we've still got a little way to go. We've still got winter to get through. Our borders are back open again, of course, and so we would expect numbers to sort of start rising again throughout the course of the year. Certainly whooping cough is more common in young people aged 15 to 19 years than in the younger adults, the 20 to 24-year-olds. So something to be mindful of when we are looking at our patients and whether they have a cough or not, regardless of their age. We should be thinking pertussis. So if we're looking at pertussis in adults or adolescents and young adults, that pertussis notification rate really decreased after, you know, 2009 up to about 2013 for both of these particular age groups, but then it peaked again, and 76 of those notifications, you know, certainly, or 76 notifications per 100,000 cases, you know, people were in the 15 to 19-year-old age group. Around about 40 per 100,000 were in the 20 to 24-year-old age group back there in 2016. So notification rates, of course, really reached their lowest point in 2020. Quite possibly, yes, we've got great vaccine programs. However, probably international border closures played some role for that as well.
And Angela, Shelley's asked a question just about the notifications.
Yes. Sure.
Are they from those that are unvaccinated exclusively or have waning protection by chance?
Oh, look, that would be a very good question, and I wouldn't be able to drill data down that to that degree. But we certainly do know that waning protection is a problem, and we are going to talk about that problem later on in the presentation. But we actually do have relatively high vaccination rates against pertussis in Australia. Certainly our adolescent program is in the school system is probably not as high as we would like it to be. It tends to sit on average, states and territories will all be a bit different, but it tends to sit only around about that 80%, if that, all right, 75 to 80%. So we've still got some work to do in making sure that these adolescents are getting their booster dose for sure. So hopefully that's answered your question to a point there, Shelley. Thank you. So vaccine effectiveness in children. A lot of people say, well, you know, it's not a very good vaccine. It doesn't last for very long, etc. And look, you know, there is a little bit of truth in the fact that, you know, we have a vaccine, absolutely. But yes, it does wane. And so there's always a lot of dialogue around that duration of immunity in children and you know, in Australian children, you know, between 1 and 3 years who had not had an 18-month booster dose, the effectiveness of those 3 pertussis vaccines that they had as infants declined progressively from 2 years of age to around about less than 50% efficacy by 4 years of age. And studies in older children have suggested that vaccine effectiveness decreases with time since the dose of pertussis containing vaccine before they start school. So that's that 4-year-old dose. But like I said, we'll talk about this waning immunity that, you know, further on in the presentation. So in regards to vaccine effectiveness in adolescents and adults, so data on the duration of immunity to pertussis after a single booster dose of adolescent formulation. So that's the little d, big T, little p, because we're looking at a vaccine unlike the childhood program, which is all capital, big D, big T, big P, with the little a for acellular pertussis. So we have less antigen content for diphtheria and pertussis in the adolescent adult formulation, but equal amounts of tetanus antigen. So long-term follow-up with adults showed a really rapid decline in pertussis antibody levels within 2 years after vaccination. And this decline steadily continued through to the 10-year mark. Although antibody levels did remain above baseline, long-term follow-up of adolescents also showed a rapid decline. Pertussis antibody levels decreased to, or certainly approached pre-vaccination levels after 10 years. So we would be pretty sure that those antibody levels would definitely not be there after 10 years. However, you know, the clinical protection is unknown with pertussis. So we can't measure clinical protection by doing a blood test, etc., like we can for, say, hepatitis B vaccines. So if we're looking at pregnant women, which we are now definitely recommending to be vaccinated, some studies are suggesting that the pertussis antibody levels in the mum decline progressively in the year after delivery. Another study suggests that pertussis antibody levels were detectable in both mothers and their infants at the time of delivery, even though the mothers were vaccinated around 13 months earlier, which is actually pre-pregnancy. So there's clearly some antibody transfer through mums that they found in some studies if the mum was vaccinated prior to pregnancy. But certainly there was better antibody protection in these infants if the mums was vaccinated during pregnancy. So in some studies, children born to women who were vaccinated in pregnancy were found to have lower pertussis antibodies a month after completing their infant program, and this sort of indicated that there may be some interference with these maternal antibodies to the childhood vaccine program, and we often refer to this as blunting. However, these antibodies really did bounce back very, very quickly, definitely by the 12-month age group, regardless. But ideally, we want to protect little babies, and that was really just a couple of studies. Other studies have demonstrated that there wasn't really that blunting effect to a degree that we would be concerned about. So we know that there's certainly recommendations in the immunisation handbook that infants and children are recommended to receive the 5 doses of pertussis-containing vaccine. And certainly if they have missed a dose, then certainly you would be catching them up with the infant formula of DTP if they are less than 10 years of age. And the government set this aspirational target of reaching 95% protection in these young children. So we know that infants do receive those 3 primary doses at 6 weeks, 4 months and 6 months of age, and then they are followed with 2 booster doses, the first one at 18 months and the second at 4 years of age. Definitely, if the child that you're seeing is on a catch-up, and they did receive dose 4 of a DTPA-containing vaccine routinely at 18 months, then it's a valid dose and you would go ahead and vaccinate them with another dose. But if they received that 4th dose that they missed at 18 months, but they received it after they were 3.5 years of age, then they do not need to have that 5th DTPA containing vaccine. They would wait until they get to their school program, which is usually in year 7 at school, so around about a 12-year-old age group. We're at 94.54% nationally for DTP coverage for 5-year-olds. So we are just really shy, just by a few kids really, for that aspirational target of 95%. So out of interest, for 1-year-olds, we're at 94.18%. For 2-year-olds, we always take a dip for the 2-year-olds, so we're down to 92.58%, but then we do bounce up for that 94.54% coverage for the 5-year-olds. So if we're looking at coverage, this is what the graph would certainly look like in regards to your DTP. So it's a little bit hard to see where that yellow line sits, but it kind of is tracking under the blue Hib line. So we are just really almost at that 95%. And we're doing really well with all of the other vaccines as well for this age group. So then we're looking at our 2-year-olds. So you can sort of see that it starts to have this little bit of a dip down. If once again, we're trying to find that yellow line, which is your DTPA coverage. So for whatever reason, this is how the graph looks. I always find that this is really quite interesting, I suppose, because the children have these vaccines, a lot of these combination vaccines all at the same time. So why is there some difference between antigens, particularly when we're looking at the little babies getting, something like infant Hexa that's got 6 antigens. One wonders why the coverage rates are actually different. Maybe it's incorrect reporting, maybe it's adding in children who were immunised overseas with different types of vaccine combinations, but it always does interest me when there is a discrepancy between vaccine coverage for different antigens that should have been administered at the same time. So then, of course, if we're looking at those older children, those 5-year-olds, we can see that red line, which is your DTPAs, which just has been steadily climbing. There was just that little bit of a hiccup, you know, when COVID hit in early March. People were a bit scared about getting out. General practice was very scared about seeing people face to face, and so, you know, potentially there could have been a little bit of a blip in our immunisation coverage at that particular time. But remember, these coverage reports really are just a snapshot of a moment in time of a particular cohort. So with our adolescents, of course, they have that booster dose, which is around about year 7. South Australia is, you know, finally moved across to year 7, being in our first year of high school now. So, you know, we've sort of going to be concentrating more so now on that year 7 cohort. So really hard work, this group, and we'll talk about them shortly, but the fact that a lot of parents believe that the child was vaccinated in their baby program, so they don't need this booster. They may think that, oh, the child had whooping cough as a child. You know, the student had a whooping cough in disease as a child, so therefore they might have natural immunity. So there's a lot of perhaps misconceptions from parents, which is why they're not signing the consent form potentially. So this is our adolescent coverage at the moment. It's not looking too bad, but like I said, it is sort of sitting around about that 80%. We've got some states and territories that are just a little bit lower. And of course, this is obviously, you know, to 2022 data, 2020 data. So I haven't got any 2021 data to show you to whether we improved or not, but we know that there were some great big disruptions to, you know, the school program during COVID times. So with our adults, now we have a problem, don't we, with adults and older persons vaccines. We certainly don't tend to capture data the same way that we do with our childhood program. And so it's really difficult to understand vaccination coverage. You know, there's no reports that are generated. There's no graphs like I just showed you with you know, the school program and the children's program. So adult vaccination, really, we have often said, has been the poor cousin to the childhood program. But look, now that all providers in general practice and you know, all the pharmacy software transmits data to the AIR automatically, we really should be able to capture more accurate coverage data. And I suppose the question is to you as the providers, you know, do you have conversations routinely with patients around their need to have a booster if it's been more than 10 years? Is it something that comes up routinely? Do you make a point of opening Pandora's box and starting to talk about vaccines when actually they came in just for a blood pressure check and a repeat prescription? So it is really difficult because you know, providers are very, very time poor. There's certainly some reluctance to talk to patients around vaccines that are not funded. Maybe you do talk to patients about it, but because it's not funded, they don't believe that it's an important vaccine to have. Otherwise, if it was important, the government would fund it, is often the thought process. But there's general lack of awareness in adults that they should be having a booster. So with our older persons, you know, definitely adults at 65 and above, if they haven't had pertussis containing vaccine, you know, in the last 10 years, they should really have one. We know what the coverage is for this. We would expect that it would be quite poor. There was an article published by Betty Liu and colleagues that stated that although, you know, severe morbidity is highest in the youngest, people. Adults can suffer really serious complications, and reports suggesting 5 to 12% of those aged 65 with pertussis are hospitalised, and about 8% developed radiologically confirmed pneumonia. So this is certainly a disease of all ages, and we definitely need to make sure that vaccine coverage is high. So the purpose of actually, the main purpose really of giving this particular vaccine in pregnancy is, yes, definitely to protect the mum, but getting that antibody transfer to little babies so they're born with some protection. So definitely that vaccine between 20 and 32 weeks is ideal. Definitely you can vaccinate them after the 32 weeks, absolutely you can. But we definitely want this vaccine into the pregnant woman at least 2 weeks prior to her delivering her baby. So it gives time for those antibodies to transfer across. So vaccination in pregnancy, or if women are breastfeeding, is very, very safe. The vaccination during pregnancy is really, really vital, and it has demonstrated that it does protect young infants against pertussis by about 90%. Studies have really found no evidence of an increased risk of adverse pregnancy outcomes related to getting vaccinated, the vaccine being given in pregnancy, and certainly have found that babies born to mothers who have had a pertussis vaccine in pregnancy had higher levels of antibodies against the disease than babies whose mums were not vaccinated. So if you're vaccinating the mum after delivery, maybe she just wasn't offered it, maybe she refused it in pregnancy, for whatever the reason, vaccinate her after delivery, because it could reduce the likelihood of pertussis in the mother, as well, for the mother contracting pertussis. And because she is going to have very close contact to her little baby, then she's got the potential to spread the disease to her infant that won't have any or very little immunity. So we would definitely want this mum to be vaccinated before this baby is born. So there are recommendations around people who care for little babies or household contacts of little babies, because we know that infants who are too young to be fully immunised do have that highest risk of pertussis infection and really severe illness, and a high proportion of hospitalisations, and almost all deaths from pertussis occur in this very, very young age group. So we know pertussis infection in infants less than 6 months of age is quite often associated with that significant morbidity, and the source of infection in infants is often from a household contact. Parents mostly, in around about 50% of cases, and then followed by siblings. So definitely, if you're a healthcare worker, you are breathing on little tiny babies, please make sure that your boosters are definitely up to date. There's a lot of new parents that are really instilling a no vax, no visit policy. So don't come and see the baby unless you've had your vaccine. However, realistically, if women do receive this pertussis vaccine in pregnancy, in addition to all of the visitors having the vaccine, then, certainly there's, good protection for the baby. It's really a bit of a cocooning, I suppose, if people other than the mum get vaccinated. But unfortunately, mums do take these babies out of that cocoon. It's fine to have all of their close friends and family getting vaccinated, but as soon as they take that baby to the supermarket or the netball courts or the school grounds or wherever that baby goes, it's out of the cocoon. So it's really relying on those antibodies from the mum, because we've vaccinated the mum. So we probably really need to start changing our dialogue and saying pertussis is a bad disease for everyone. And if everyone has not had a pertussis booster for more than 10 years, then they should certainly be seeing their provider and getting one.
And Angela,
yes,
Angela in the Q&A has asked, do those well-meaning relatives need to update their boostrix with every new addition to the family, or is there a timeline? Can we just clarify that?
For sure. Look, pregnant women get this vaccine with every pregnancy, regardless of the interval between pregnancies.
Yes.
For everybody else, it's 10 years. So the grandparents don't need to get reboosted every time someone in the family gets pregnant. It'll supposedly give them protection for 10 years. We'll see, but that's kind of what the handbook is telling us at the moment.
Thanks,
so,
that's great.
Okay. All right, so definitely healthcare workers, early childhood educators and carers for reasons that we've already mentioned, and there's no adult that would wish to contract pertussis themselves, nor be responsible for infecting a vulnerable infant. So or any other person for that matter. So all healthcare workers definitely are recommended to receive, a booster every 10 years. And some maternity hospitals are boosting their staff every 5 years. So your organisation, may have their own policies around that. But we definitely know that adults who provide the early childhood education and care for infants and young children aged under 4 years of age really should be receiving that whooping cough booster, and it just might not quite be that well understood in some of these industries. So with our adolescent pertussis vaccine, so this is our school, what we refer to as the school immunisation program. So generally it's now going to be to year 7. And, we've already alluded to the fact that, there is this waning immunity. So a booster dose is really, really important for this cohort, and it is a funded vaccine. And under the no jab, no pay legislation, this dose remains funded under the NIP for individuals right up until their 20th birthday. Once they've had their 20th birthday, if they have missed catch up this dose, then it's not a free vaccine for them. So they do have ample opportunity to get caught up to date, but we do know that it is up to the providers quite often to keep reminding them and certainly checking air, making sure that they've had that dose and vaccinating them if they haven't. Obviously, refugees and other humanitarian entrants over 20 years of age are still eligible for free catch-up vaccines on an ongoing basis under the standard NIP. We know that students miss these school visits quite regularly, for a lot of reasons. The child may be sick, they may be away on a school camp, in detention, whatever it might be. But, the school program providers do attempt to follow up students who do miss vaccination in the school if the parents did consent for it to occur. General practice providers, really should take every opportunity to check the Australian Immunisation Register during the consult with an adolescent, just to ensure that they are up to date, and certainly offer any catch-up vaccination if it's needed. And while many states allow, Boostrix or Adacel vaccination in pharmacies, most pharmacies do not have most of the pharmacy vaccination programs have a minimum age restriction of either 16 or 18 years of age. So it is important that general practice or the school program provider themselves follows these students up if they've missed doses. So the World Health Organization, or the WHO, certainly has a global vaccination plan, and this is expected to be ongoing. This one here was certainly up to 2020, but I think the WHO has been a little bit busy with COVID since then to be thinking too much more about other vaccine-preventable diseases. But they certainly have great insight into all vaccine-preventable disease rates around the globe, and definitely acknowledge the success and the positive impact of vaccine programs. And I think the key here is that the benefits of immunisation are equitably extended to all people. That is, no matter a person's race, religion, colour, age, or health status, all should have equitable access to vaccines. And that includes older people. And we definitely say that vaccination is for all people at all stages of life. Adulthood, you might be surprised to learn, is longer than childhood. It lasts much longer than childhood. Life expectancy in Australia, it has continued to rise and will continue to rise. For example, a baby boy born now would be expected to live to 81.2 years of age, and a girl to 85.3 years of age. And that's according to the ABS statistics in November 2021.
Angela, we seem to have lost your audio at my end.
Are we good to go?
We are good to go now. Thank you.
Okay, good. No worries. Okay, so adult pertussis vaccination. So let's look at the reasons we should be vaccinating adults. Recently, there's been an increase in reported cases of pertussis in adolescents and adults, and this has been across many countries, despite high immunisation rates in children. We know that adults are a reservoir for infection in very young infants, and we know that infection in very young infants may well be severe and life-threatening. As we age, we have a problem called immunosenescence, and this is the alteration of immune function due to ageing, and we'll talk a little bit more about this. Data does suggest that pertussis in the elderly and those with underlying chronic conditions or comorbidities can result in significant morbidity, mortality, and costs. So we know, I think fairly clearly, that this is a disease not just of childhood. We can, look at data that is relatively old data here, but even between 2008 and 2012, which is an extension from this particular graph, all Australian states experienced their largest pertussis epidemic. The highest rates of disease were in infants less than 6 months, and then in children aged 5 to 9 years. And, certainly this graph from South Australia, we can actually see that 66% of notifications in this particular age range were in adults 20 years and older. So it is a problem. A single booster of pertussis containing vaccines definitely recommended, as we've said. But just remember, we talked earlier that, if they're 65 and over, definitely be recommending it if they haven't had a dose since they were, in the last 10 years. But just remember that adults are also recommended to receive a tetanus booster dose at 50 years of age if they've not received a booster of tetanus-containing vaccine in the past 10 years. So the handbook says this dose should be offered as a DTPA, so it also can protect them against pertussis as well. They are not funded vaccines. The tetanus is not a funded vaccine. A DTPA booster is not a funded vaccine, but definitely about it. I don't believe that it's an overly expensive vaccine. And remember, when people are purchasing vaccines, let their fingers do the walking, shop around, get different prices from different pharmacies, because they'll all be very different. If they've got private health cover, check with their health fund, and they will probably get a rebate of some description back from their health fund. So getting into the nitty-gritty very quickly here, because we've got still a fair bit to get through. Definitely, there is, this significant pertussis outbreak problem. We know that these epidemics occur around about every 3 to 5 years. So this is quite a cyclic disease. And whenever we do look at pertussis graphs, we can see these, we can see peaks and troughs. And we know that there's a problem, with this waning immunity. And so we will continue to see peaks and troughs for sure. So pertussis, as we know, is a human disease. There's no animal or insect source or vector that's known to exist. And so, adolescents and adults and older school-age children are certainly a reservoir for Bordetella pertussis. And really, we need better research, I suppose, to help us better understand the duration of immunity, which in turn will shape booster vaccine recommendations in the future. So you can see through this slide that, we were using a whole cell pertussis vaccine, very, very early in the stage, gave very good protection, but because of adverse events in young children, we switched to an acellular pertussis vaccine. But I think this immunosenescence is probably the one that's causing a lot of issue, particularly for older people. We know that there's an impact on the immune system as we age. It wasn't such a problem when the human lifespan was only 40 years, but certainly we've had some big advances over the years, and our life expectancy is much higher than that now. And so this immunosenescence really implicates the changes in the adaptive immune system, and particularly within T cell and B cell populations. So overall number of T cells in circulation remains relatively constant, but perhaps there's a real striking change that occurs within that aging T cell compartment that really diminishes the output of the new naive T cells. So our CD8 T cells have been basically referred to as our foot soldiers in the immune system, and during an infection, these naive CD8 T cells are primed by those antigen-presenting cells, and then they become active in fighting infection. So if we've got less of these cells because of our aging processes, then our ability to fight infection is compromised. And therefore, because our vaccines are trying to mimic infection, then we don't respond as well to vaccines as either. So the CD8 and CD4 ratio really is a biomarker of both persistent inflammation and immunosenescence. And the lower that ratio value, then it compromises that immune response and contributes to inflammation. And certainly a low ratio predicts immunosenescence. And so then we're looking at the telomerase. It's the enzyme that's really responsible for maintaining the length of telomeres, and definitely aging is characterized by that progressive telomere shortening due to cell division and erosion. So telomeres, shorten naturally with every cell division. So the older we get, the shorter the telomeres become. So immunosenescence really is a major problem. There's not much that we can do about it. It's part of how our human bodies work, but we perhaps just need better vaccines in order to, have better coverage, really. But we need to get it in these vaccines into arms in the first instance. A vaccine's not very good if it's sitting in the fridge. So we know that this is really underestimated disease in adults. Diagnosis is often missed, misdiagnosis as well, underreported. And data does suggest, 20 to 35% of subacute coughing illnesses in adults are actually due to pertussis infection. And although death in individuals older than 10 years of age is rare, you know, they are a source of infection for those more vulnerable groups for sure. So classic symptoms, you know, may not exist in the adults, you know, particularly early in the diagnosis. So get a really good history from this person. Have they had contact with someone with a prolonged cough? Or after they have had a coughing fit, do potentially they vomit? That might be a bit of an inkling, because, you know, we really do need to be testing more individuals if they have had a cough. A lot of adults don't get tested. They won't come and see a health provider. They'll just soldier on because it just becomes, you know, a cough that's just really annoying, but they'll put up with it. And usually by the time you've diagnosed them, it's too late to give them antibiotics, and they've been out in the community infectious, and they've probably infected it. Last poll for the night is, according to the Pertussis cDNA national guidelines for public health units, which test would be preferred for diagnosis of pertussis? Okay, yes, certainly the NAT, or PCR as it's commonly known, has really replaced culture for the diagnosis of pertussis. It's a lot more sensitive than culture, so definitely be using that. Steer away from serology, realistically. There's some problems with serology if it picks up other Bordetella pertussis type species, such as Pertussis, etc. So you're better off doing your NAT for sure. Okay. The other issue with serology, it can take a while as well. So yeah, we'll be definitely a NAT PCR. So just really saying that we just need to vaccinate people. That's what this slide is actually really telling us to do. It also tells us that, you know, there is this waning immunity, that people are probably able to pick up infection well inside of that 10-year period of time. And yeah, once again, we just need perhaps a better vaccine that works on our immune systems a lot better. So really quickly, underlying medical conditions, definitely we've got, you know, almost half of Australians have got at least one chronic health condition. So we know that pertussis, it can be more severe and lead to hospitalisation in these particular patients. So if we're looking at immune compromised individuals as well, you know, most definitely the lung is one of the most frequently involved organs in a variety of complications in the immune compromised host. So infection, you know, in the lung, so leading to pneumonia, really is bad news for these particular people, and will quite often require some hospitalisation with a pneumonia. High BMI also, so if you've got patients who are a little on the weighty side, or they're on certain medications, if they have smoked or are current smokers, once again, that will increase their risk of requiring hospitalisation with pertussis. So there's been some studies done around vaccine effectiveness, but realistically, it's just once again demonstrating that there is waning, and that waning is more for people who have had the acellular pertussis vaccine versus the whole cell vaccine as their first dose of vaccine. So there is some work being done at the moment with perhaps giving little babies a whole cell pertussis vaccine to start their vaccine program. But you know, realistically, we'll just need to wait and see. It's an ever-changing landscape, is the bottom line. So in regards to strategies, how do we you know, increase uptake? Is it better education of healthcare workers? Is it better education of community? Is it funding the vaccine for adults? is it better measuring and reporting of uptake like we do with the childhood vaccine? So there's a whole range of questions there. Perhaps the best way to increase uptake actually lays with you, and that is asking every person that you see around their pertussis vaccination status. You remind patients, use your recall systems, be opportunistic, open the conversation, whether it's a funded vaccine or a non-funded vaccine. We are seed planters, and we need to plant the seed in the patient so they can go home, have a little think about it, and then get back to you. So, quick summary, happens across all age groups. Certain individuals are at higher risk of severe disease and hospitalisation with complications. So, but the biggest take-home message really is get this vaccine into people's arms and babies' legs. And that's the best thing that we can possibly do. So, sorry, hopefully we've got time for a few questions.
No, that was fantastic, Angela. Thank you for being so thorough. Some of the questions may be quite quick to answer. So we'll start with Shelley, just on how long a patient with pertussis would remain infectious.
So for about the first 3 weeks of coughing.
Great.
They remain infectious.
Very good. And what do you know about A&E's recording of the DT vaccines? Do you know if that's something they routinely do? We do have an attendee, Robin, who said, I believe generally not. I'm not sure if you have any other info.
So who?
A&E's, Accidents and Emergency Centres.
Oh, yes. Look, yes, we do have a little bit of problem with hospital vaccines being reported, because not everyone in the hospital may have access to the AIR. It might have just been a particular unit, but check with your hospital, because if you are connected to the AIR and you can add records on, then you would need to manually add it on, because your hospital software won't transfer it to the AIR. So, but we would love for you to add it on if you've got access to the AIR.
Great, fantastic. And finally from Carolyn, do women who are vaccinated after delivery receive government-funded Adolescent?
No, it is only during pregnancy. So if they're no longer pregnant, then they're not part of that maternal vaccination program. They would need to pay for the vaccine.
Terrific. And one's coming in now. If a patient has a DT booster within a month and the patient needs DTPA because of a new baby born, can the patient have whooping cough vaccine?
Look, there used to be a, no, you can do it at any time. The immunisation handbook now does suggest that you do wait a period of time. However, it's important to protect these people against pertussis. So we would need to weigh up the risks of an adverse event such as a big red swollen arm, because that's probably what they would get from two tetanus-containing vaccines so close together. Sure. So, yeah, it's just important to protect pertussis. So it's a risk-benefit ratio.
Fantastic. Well, as usual, Angela, you've been amazing. And we thank everybody in the audience as well for some great engagement and questions, comments. There is one actually that I promised Rosemary that I would ask you. So if you do still have a moment, I'm going back through the chat. Here we go. I have found that generally the childbearing age population and potential grandparents are encouraged to have a pertussis vaccine. When a patient presents with a tetanus prone injury, nurses tend to recommend this vaccine as well. Is it better to offer to everyone and not just this group?
Look, absolutely. Look, when someone presents with a tetanus prone injury, you as a provider, your main objective right at that point in time is to protect them from getting tetanus. And that's why you get the, ADTs in your doctor's bag, basically. So they're free in the fridge for tetanus-prone wound post-exposure prophylaxis. However, if you've got a pharmacy next door, or you stock Boostrix or Adolescent vaccines and sell to your patients, so private stock, then absolutely be talking to your patient about it. They would need to pay for the vaccine, though, if it was a DTP. whereas for a tetanus-prone injury, they would get the ADT for free.
Terrific. Well, thank you again, Angela. That's wonderful. I will just tell the audience before we leave that we have an RSV in Australia webinar coming up on Wednesday, October 12th. We'll have registrations open for that next week in our newsletter. So if you'd like to go to the chat and copy and paste that subscription, you're welcome to do that. Presenting that will be Professor Philip Britton and moderated by Professor Robert Boy. Angela's slides and a recording of this event will be made available soon on our website. And also, if you could take the time, very short 3-question survey at the end of this event, we'd really appreciate your feedback, and hopefully we can continue to bring you some great educational events. So once again, thank you so much to you, Angela, and everybody stay safe and good evening.
Yes, good evening. Thank you, everyone. Bye.
Thank you.